Now we'll pick up the most common fractures of the upper limb and we'll try to discuss them. And this discussion is towards how can we be able to manage them, that's treat them if they occur. So we'll be looking from the shoulder downwards to the wrist. So look at shoulder dislocation, we look at supracondylar fractures, we look at Colles fractures, we also look at the Monteggia fractures. So if they occur, how can we be able to, you know, solve the issues when they occur? You know. So generally, you should know that before you treat them, you always check to see if there was no injury to the nerves or the blood vessels. Very important. Very, very important. So let's start with shoulder dislocation. So if there's a shoulder dislocation, um, close reduction. So you do some maneuver so that what the head of the humerus goes back into the glenoid fossa. Those are the reductions. Then you immobilize with a sling where you tie something around the neck to hold the hand so that you don't keep shaking. They can do eyes, analgesics, physiotherapy just to reduce pain, strengthening of the rotator cuff and scapular stabilizers. Surgical intervention is indicated for cases that keep happening. Okay. Then also arthroscopic Bankart repair or ligament tightening may be performed. For supracondylar fractures, that's in children, type 1 is undisplaced, immobilized in an above elbow back slap at 90 degrees for 3 weeks. Type 2 is displaced, gentle close reduction. That's supracondylar fractures where there's a fracture, around this place. Okay, see, it's a supracondylar fracture. So this is the one we're talking about. Then type 3 and 4 is complete displacement, is urgent reduction and percutaneous K wire fixation. You see all these wires, all this black stuff on X-ray is a K wire that we're talking about. Okay, so Colles fractures now. It's a fracture around the wrist. Okay, so close reduction of the displaced fracture. Reduction is just like you are trying to bring back the bone that moved out of position back to position. The immobilization with a plaster or splint, just like what you see here. You know, the surgical fixation is required if fracture is unstable, comminuted, or intraarticular. So they can also use pins, they can use plates, they can use screws, they can use external fixators. Then they can rehabilitate where they can put the cast there, you know, for over 6 weeks. Then physiotherapy where they are trying to, you know, how I put it, supervise how the patient is restoring motion and all of that. And for Monteggia fractures, where there's fracture of the ulna and the radius, where it's fracture of the ulna, proximal ulna with dislocation of the radial head. So close reduction, you're trying to actually reposition the bones. Then you can also use fixations. Okay, internal fixations. The radial head reduction must be confirmed radiographically. So I think that's it. So children, you can do with close reduction and casting, while for adults, require surgical fixation due to instability. They can also do a cast or splint for you for about 6 to 8 weeks, just to keep that place immobile, so that you can, recover very well. So I think this is what we have as regards these fractures. And bye for now.